Welcome to today's Explainer. Today, we're diving deep into a topic that's absolutely vital for your NEET PG prep and your ward postings: fetal congenital malformations on ultrasound. This is a 5-star, mega high-yield topic, right? We're going to decode the ultrasound markers, the clinical pictures, and the biochemical markers, focusing purely on building crystal-clear concepts. So, let's get started.
All right, here's our quick roadmap for today's session. We're going sequentially from head to toe. We'll start with USG basics and TIFA, move on to cranial and caudal neural tube defects, then tackle abdominal wall defects, and finally wrap up with biomarkers and prevention protocols.
Okay, Section 1, USG basics and TIFA, the investigation of choice.
Now, listen carefully. While a level 1 routine ultrasound might pick up some malformations, like certain neural tube defects, it's just not definitive enough. For gross structural anomalies, the gold standard, the absolute investigation of choice, is your TIFA scan. That's targeted imaging for fetal anomalies, or level 2 USG, usually done between 18 to 22 weeks. So, golden rule, for gross anomalies, go for TIFA. But if you suspect a chromosomal anomaly, then you must proceed straight to karyotyping.
Moving on to Section 2, cranial neural tube defects, journeying from acrania to anencephaly.
Let's clear our fundus on this classic step-by-step pathological cascade. It starts right at the top. First, the cranial neuropore just completely fails to close. What happens next? You get acrania, literally the absence of the skull, meninges, and muscles. Because there's no covering, the delicate brain tissue herniates right out into the amniotic fluid. Are you following me? That harsh exposure causes massive destruction and degeneration of the brain tissue. And the end result of all this? Anencephaly.
But what if that cranial defect is small? Well, then you get an encephalocele. Here, the meninges and brain tissue do herniate out, but like anencephaly, they are actually covered by meninges and scalp. You can see a very distinct sac forming. And mark this in red for your MCQs. The most common site for this encephalocele is the occipital bone.
Now let's jump back to anencephaly for a second and compare the clinical picture to what we see on an ultrasound. Since there's no cranial vault, the facial structures end up looking very prominent. You get these deep, deep sockets and big bulging eyes. When you see this on an ultrasound, it gives us that classic, unmistakable frog eye sign.
All right, focus here, because these are straight, high-yield MCQ points for your exams. Anencephaly is the very first congenital anomaly you can pick up on ultrasound. You can spot it as early as 10 weeks, but the absolute best time to detect it is at 14 weeks. Also, because the pituitary and adrenal glands are either absent or severely hypoplastic, the fetus develops a swallowing defect. And what does that lead to? Polyhydramnios. They are strongly associated. Face presentation is also the most common here. And don't forget the 3 classic ultrasound signs: the shower cap sign from the irregular head contour, the Mickey Mouse sign from the triangular face, and of course, the frog eye sign we just talked about.
Section 3. Let's look further down the spine at caudal neural tube defects, specifically spina bifida.
Let's break these down simply. We have 3 main types. In spina bifida occulta, there's absolutely no herniation of the meninges or the spinal cord. You might just see a tiny tuft of hair on the overlying skin. In a meningocele, only the meninges herniate out to create a sac. And then we have meningomyelocele. This is the most severe form, where both the meninges and the actual spinal cord herniate right into that sac. By the way, meningocele and meningomyelocele together, they're commonly referred to as spina bifida opera. When you're doing a scan and you suspect a severe neural tube defect, you must pay very close attention to the fetal brain. You're going to be looking for 2 major diagnostic markers, which, by the way, are also seen in Chiari-2 malformations. First, the downward displacement of the cerebellum pulls it into a curve, giving us the banana sign. Second, the inward scalloping or bossing of the frontal bones gives us the lemon sign. Keep an eye out for associated ventriculomegaly and polyhydramnios too.
Moving on to Section 4, abdominal wall defects. This is a classic battle: omphaloceal versus gastroschisis. The fundamental clinical difference here is all about the covering. In an omphaloceal, the herniated abdominal contents are safely packed away, neatly enclosed inside a protective sac. But in gastroschisis, the herniated bowel is just completely exposed, floating right out there in the amniotic fluid without any sac at all. Translating those clinical differences into ultrasound findings and management is super crucial. Because an omphaloceal is enclosed in a sac, it gives a very smooth outline on your USG, and you'll see it originating directly from the umbilicus.
Gastroschisis, on the other hand, lacks that sac, so it has this messy, irregular, cauliflower-like appearance, usually sitting to the right or left of the umbilicus. And here is the most important takeaway. An omphalocele absolutely requires karyotyping. Why? Because it has a massive association with chromosomal anomalies, specifically trisomy 18 and 21. Gastroschisis, no routine karyotyping required.
Please grab your pens and write this clinical pearl down in big red letters. You must never, ever diagnose an omphalocele before 11 weeks of pregnancy. You know why? Because physiological herniation of the midgut through the umbilicus is a completely normal, natural part of fetal development up until that 11th week. We only slap the omphalocele label on it if it persists after 11 weeks. Crystal clear? Good.
All right, final stretch, Section 5, Biomarkers and Prevention.
It's really important to understand how our obstetric protocols have evolved. Back in the day, our go-to screening test was measuring maternal serum alpha-fetal protein levels, and the diagnostic test was an invasive amniocentesis. Today, the entire paradigm has shifted. Our primary screening test is the Level 1 USG, and that targeted Level 2 TIFA scan has become our definitive diagnostic test.
Now, even though ultrasound is king right now, you still need to know your basic fundas about alpha-fetal protein, or AFP. It's a fetal-specific globulin synthesized primarily by the fetal yolk sac, the GI tract, and the liver. Here's a crucial stat. The maximum level of AFP in fetal serum hits exactly at 13 weeks. But listen to me carefully. If the examiner asks for the absolute best biochemical marker specifically for neural tube defects, the answer is acetylcholinesterase, not AFP, acetylcholinesterase.
Distinguishing between the causes of raised versus decreased maternal serum AFP is an all-time favorite question for examiners. You see raised AFP whenever fetal contents are basically leaking into the amniotic fluid. Think neural tube defects, abdominal wall defects, pilonidal sinus, or sadly fetal death. Now for decreased AFP, you just need to memorize the GOAT mnemonic. G for gestational trophoblastic disease, O for overestimated gestational age, A for abortion, and T for trisomy of the fetus. Remember the GOAT.
From a management standpoint, prevention is everything. For a normal, low-risk pregnancy, the folic acid supplementation dose is 400 micrograms per day. But if your patient has a previous history of a neural tube defect, you need to know that exact 4 mg per day dose to prevent recurrence. Speaking of recurrence, the risk is 5% after one NTD, and it doubles to 10% after two. Lastly, because anencephaly is completely incompatible with life, the management protocol is straightforward. Medical termination of pregnancy, or NTP, is indicated irrespective of the gestational age, of course after proper medical board approval.
Okay, before we completely wrap up today's session, let's do a quick active recall test on a crucial distinction we covered a few minutes ago. Think back to that sac versus no sac comparison. Do you remember which abdominal wall defect requires karyotyping? That's right, it's omphalocele, because of its high association with trisomy 18 and 21.
By mastering this head-to-toe diagnostic journey, you aren't just memorizing facts for an exam. You are equipping yourself to be a sharper, more confident clinician who can properly guide patients through what can be very complex pregnancies. But I want to leave you with a thought. As high-resolution ultrasound and AI algorithms continue to advance at lightning speed, do you think we will soon reach a day where invasive karyotyping becomes completely obsolete for these structural defects? It's something to think about. Keep revising, clear your fundus, and I will see you in the next explainer.